2 o'clock. Thank you for joining us today.
Hello.
Hey, how are you today?
Good. Sorry for the last minute. I just got off another call, another Zoom session. I've got them back to back for 7 hours today.
Oh my, that's a lot. Hopefully you don't have to do the talking the whole time at all of them.
No, this is the only one I have to, well, I talk and then Al talks on this one, but is he on? Yeah, there he is. Good.
He is, yes. Well, we will get started right at 2 o'clock.
Before every one of these sessions, I go in the bathroom, make sure my shirt is good and my hair is combed, and then I realize I'm not on camera. So then I can go back to being my normal slob. But most of them that I do they do have a camera, so I have to like clean up a little bit.
It's nice to not have to do that for this.
It's true. Yeah. Have you ever asked your audiences though if it matters to them? I just don't know if I do so many of these that I don't really have a sense of whether people value being able to see the speaker or not.
Well, we don't really ask because it's not something that we offer with our webinars. We do offer it with our workshops. We have it on, but with our webinars, we don't offer it. So it's not something we've really ever asked. Just for anonymity, we just try and keep it that way. But yeah, so I'm not really sure. I don't have an answer for that one. And with that, we'll go ahead and get started. So good afternoon, everyone. And I'm Rebecca Vickers. And on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode, and you will not be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the chat panel. The button to open the panel is usually located in the upper or lower right side of your monitor. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options are also posted in the chat panel. If you continue to experience poor audio through your computer, try rejoining the webinar and use the I will call in telephone option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on FADAA's website within 30 business days. To access the recording and PowerPoint, go to www.fadaa.org, then to our Resource Center, and then to our training library. FADAA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credits for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on FADAA's website. You will first need to register or sign into your account to complete the evaluation. Information you provide FADAA as a part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note the evaluation will close midnight, Monday, March 28th. Up to 1 continuing education credit is available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide your certification number when you register with our site. Please note that WebEx monitors arrivals and departure of attendees and provides a report upon completion of the event. We are not permitted to provide a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial CE credit. And today we have 2 presenters for you. So we have Mr. Albert Hassan. Albert Hassan received his MSW from UCLA and has worked in the field of addiction medicine as a researcher, treatment provider, and trainer since 1977. Mr. Hassan participated in development of evidence-based matrix model and established the Matrix Institute on Addictions Los Angeles, an opioid treatment program serving individuals who have co-occurring mental and physical health and substance use disorders. Mr. Hassan served as node coordinator of the Pacific Region node of the National Institute on Drug Abuse Clinical Trials Network, and as a project director and trainer for the Pacific Southwest Addiction Technology Transfer Center at UCLA Integrated Substance Abuse Programs, where he trained mental health, corrections, and substance use disorder providers on motivational interviewing, cognitive behavioral therapy, contingency management, co-occurring disorders, and the American Society of Addiction Medicine criteria, and medications for opioid use disorder. Mr. Hassan is currently working as a private consultant. We also have Dr. Rawson joining us again today, who we introduced yesterday. And now I will turn the presentation over to Mr. Hassan and Dr. Rawson.
Very good. Good afternoon, everyone. And we have a lot of material to cover. I apologize, we tend to do that. Al and I are not good at trimming our materials down. He actually has more than he's going to be able to cover, but we wanted to give you some flavor of what these different treatment approaches are that we're going to be discussing today. You should know that in the last 3 years, there's been a great deal of interest in this topic and getting materials out on what are the evidence-based treatments for treating people with stimulant use disorder. And there's a number of resources you should know about. SAMHSA has just recently, within the last 6 months, published a tip 33, a revised tip 33 on treatment of stimulant use disorder. I think it's I think they did a great job, and it has a lot of good information on stimulants and their effects, and then reviews the various treatment approaches. And what we're going to present is very consistent with what they list as the evidence-based treatments. Also, the VA has completed a set of guidelines, and I'm currently working with ASAM and American Association of Addiction Psychiatry on guidelines, and we're far enough along that I can say what we're presenting here is very much in line with what all those guidelines are. So I think you're going to get a fairly up-to-date picture of what we think are the treatments that have the best research support. And in Al's section, he'll be giving you some flavor of what those treatment materials actually look like. Okay, I don't seem to be moving my slides. Oh, is that it?
Yes, try that now. I'm sorry about that, Dr. Olson. Try it. See if it works for you now.
All right, well, it's not yet, but there we go. Okay. Yeah, as I mentioned yesterday, I still have an appointment at UCLA where I was for 40 years, where Al and I did all the work on stimulants that we have based our expertise on. And now I live in Vermont, where I'm originally from, and I'm part of the University of Vermont Center on Rural Addiction. So we're going to give you information on contingency management, then on a number of other behavioral treatments, and the last one will be a little bit of information on the use of exercise as an evidence-based treatment. Here are some of the clinical challenges, and we review this specifically because a lot of places where we're talking, the clinical workforce has spent the last 10 years very focused on opioids, and they have not sort of systematically thought about, well, how is treating people with methamphetamine use disorder and cocaine use disorder, how is it different? How are the challenges different? And so these introductory slides just kind of try to highlight some of the really key issues with this population who use methamphetamine and cocaine. Overdose death, I beat that to death yesterday in the talk. The next two, a limited understanding of stimulant addiction and ambivalence about the need to stop. This is a huge clinical challenge. Unlike people with opioid use disorder, who often show up in treatment, not necessarily because they want to get into recovery, but they don't want to be sick. And so they'll show up to avoid withdrawal symptoms. And oftentimes they're very urgent about getting into treatment because they want the medication. Well, A, we don't have a medication. And B, people with stimulant use disorder, their use tends to be more episodic. They don't have to use every day. They can use 3 days, then stop for a few days or a week, then they go back to using. And so in their own mind, they often think they're not addicted. They often think, well, I can stop and start on my own. So I'm using what I want to use. I'm not using like that guy who uses heroin or fentanyl, who has to use because he or she gets sick. I can stop and start. So I'm not really addicted like they are. If you don't think you're addicted, you generally don't think you need treatment, or you may not think you need to reduce your use. So this is a really big issue with this population. If you're, as I mentioned yesterday, if you're one of those people who really, really likes to work with the motivated people, you may not find this to be too much fun, because many, if not most of the people who are pushed in the door or found themselves entering treatment for stimulant use disorder are not really all that gung-ho about this process. So you're working with a group of very ambivalent people, which will be one of the things Al will talk about with regard to the use of motivational interviewing, which is particularly helpful in working with that population. These folks have, after they've used methamphetamine and cocaine, meth particularly, they've got some really significant brain difficulties, impulsivity, poor judgment, cognitive impairment, poor memory, paranoia. All of those things are on display with most of people with these disorders at the time they show up in a treatment program. Over the course of their recovery, one of the big challenges is anhedonia. Anhedonia is the inability to experience pleasure. That's a result of their dopamine system having been downregulated because of their use. So when they get into the first weeks and months of their recovery, they don't feel good. It's not like they're sick like somebody with an opioid use disorder, but they just feel blah. Life seems gray. Life sucks. Nothing is enjoyable. Going to treatment is stupid. And it produces a brain state that is very compatible with dropping out of treatment. Why do I have to go to this stupid treatment? It's not helping. Nothing feels better. And so this anhedonia, which is almost universal for the first several months with people, they don't have it necessarily every single minute. They kind of go in and out of it, but you will see it, and you will experience people who on one day come in and they like their recovery, they like their counselor, they like doing exercise, but the next day they come in and everything sucks. And if this is how it's going to feel to be sober, I can't live like this. You'll hear a lot of that with people with meth use disorder. When they're using methamphetamine, they become hypersexual, lots of sex, lots of partners, lots of, extreme sexuality. When they stop using, they often have no sexual behavior, or they have trouble functioning sexually, and it becomes a big concern and often a relapse justification. We mentioned the paranoia, which can, when they become psychotic, make them at greater risk for violence. The mechanism that they are most struggling with is this powerful craving that, unlike opioid use disorder, which generally comes from this fear of withdrawal, and I got to get some more drugs so I don't get sick, so I won't go into withdrawal. With people with stimulant use disorder, it's something triggers the craving, something associated with their use, a friend, a part of town, a time of day, getting money in their hands. And it just is an automatic thing. It's not a logical thing. It's not a rational thing. It happens at a lower area of the brain where it just becomes, I want to use. And I don't know why I want to use. All I know is I have this overwhelming feeling I want to use. Often happens very dramatically, unpredictably, and they have no idea what hit them. And part of treatment is working with them and helping them understand that. And as a result of all those things, they have poor retention in outpatient treatment. And as we talked about yesterday, getting them in treatment, keeping them in treatment is the ball game. So this is an issue. The retention is a really big challenge. These are some of the groups that are most challenging. The top two, those who inject and who use daily, come in with more severe methamphetamine use disorder, stimulant use disorder. They often will need to start treatment in a higher level of care, and their treatment prognosis is more challenging. Some other groups there who certainly require individualized care to address their particular issues are important. One group that there's a great deal of concern about are people who are on medication-assisted treatment for opioid use disorder, people on buprenorphine and methadone who got on for their opioid use disorder and are now using stimulants. In San Diego, California, that's roughly 60% of the people on medication-assisted treatment are using methamphetamine. And so it's made a mess of some of the opioid treatment efforts. Just to highlight this fact about their ambivalence on the front end of treatment, these are data from the state of Washington, a syringe exchange program, where they did a survey with about 600 participants. 400 or so were people who primarily used opioids, 140 were those primarily used methamphetamine. And they asked them all sorts of questions, but the one I just wanted to highlight here is 82% of the individuals who said opioids were their primary drug said they recognized that at some point, not today necessarily, but at some point, they were going to need to reduce their use or stop their use and or enter treatment, 82%. Less than half of that, well, about half of that percentage, 46% of the number of individuals who use methamphetamine expressed that sentiment. So you get a much lower proportion of people using methamphetamine who recognize they've got a problem or feel like they need to do something about their problem. One last study, this was from, this was just published a couple of years ago. This group analyzed the set of studies. They did a meta-analysis of a treatment dropout. They looked at 151 studies with 27,000 participants, and they looked at populations who were in outpatient treatment for heroin addiction, alcohol use disorder, methamphetamine use disorder, cocaine use disorder, and tobacco use. And they looked at the proportion of each of those groups that dropped out of treatment within the first 90 days. So this gets at this issue of retention and treatment. As you can see, about 25% of the individuals who used heroin dropped out. Now, that would be much higher if we didn't have methadone and buprenorphine. If we didn't have methadone and buprenorphine, that would be closer to 90% that drop out of treatment within the first 90 days. Individuals with opioid use disorder are very tough to keep in treatment without medication, but we have those medicines. Tobacco, about the same rate of dropout. Alcohol, same rate of dropout. Individuals who use cocaine, it's almost double that. And individuals who use methamphetamine, it's more than double. So you have the two stimulants are obviously the people who use those drugs are at a much higher rate of risk for dropping out of treatment early. So as we develop treatment, it's really important to think about what kinds of interventions do the best job at engaging, bringing people into treatment, and holding on to them to keep them coming back. You can have the best treatment program with the best therapists in the world, but if people aren't staying in treatment, they're not going to benefit from it. And so there's a real priority for thinking about what are the things we can do to get that early dropout, reduce that early dropout rate. And this is I mentioned this a minute ago, this was also data from Washington, 800 patients who came into treatment for opioid use disorder. About 2/3 of them were basically just using opioids. 1/3 of them were using opioids and they were using methamphetamine. And they tracked the retention rates of those folks across time. The top line here is the percentage of people still in treatment. The top line are those who are the individuals who use opioids only. The dashed line are those who use opioids and methamphetamine. And you can see in the first 100 days, there's a real steep drop off of the individuals who used methamphetamine. Again, this issue of when they're using methamphetamine, they don't see a need for treatment. They don't figure they're addicted to it. And it will even result in them discontinuing their buprenorphine treatment. Now, this study was done, as you can see, it's 1,000 days they've got. So that's, 3 years of tracking. I think it was started in 2015, this data collection. So the author actually says in the paper, some of these early dropouts, the dashed lines, are people who were actually kicked out of treatment because they were using methamphetamine. So they may have gotten onto buprenorphine using opioids and methamphetamine. They may have actually stopped their opioid use, but continued to use methamphetamine. And some prescribers have the policy, if you're using anything, we're going to kick you out of treatment. Again, I would hope if there's one fact you hear today from us, don't kick people out of treatment. Find other ways of dealing with that. We understand prescribers are not comfortable prescribing to patients who are using drugs like methamphetamine. However, you need to know if you discharge them, their chance of overdose death is extremely high. It goes up by a factor of about 500% that they're likely going to overdose. And so, again, these are very lethal drugs we're dealing with in 2022. The decision to kick somebody out of treatment because they're not doing their treatment perfectly is a really, I think, ethically questionable decision. So no more preaching. The data we've got on these two different categories of stimulants, cocaine and methamphetamine, we've had 5 studies where we used similar treatments with a group of people using cocaine, a group of people using methamphetamine. There was no evidence of any differential treatment response. So everything we're going to talk about here, I may have it say treatment of methamphetamine use disorder, but it really is treatment of stimulant use disorder we're talking about. And the evidence for these treatments is comparable for both. All right, this is where we start. Starting about 5 years ago, groups around the world actually started to address the question of, okay, what works for people with cocaine and amphetamine use disorder? And groups started doing these kinds of analyses called meta-analysis, which is looking at big bunches of studies, looking across the results and coming up with a conclusion based on all the results, not just one study. This was one done by a group at Oxford University and the World Health Organization. And this was the first one of these published. There actually were a couple 10 or 15 years ago, but this is the first in the current time, one of these analyses. They looked at 50 studies with 7,000 participants, 12 different psychosocial interventions, and their conclusions were contingency management. The combination of contingency management and community reinforcement approach was the most efficacious and acceptable treatment, both in the short and the long term. And in their article, they made a big point of contingency management being particularly effective at reducing early dropout. And so I think that's important to remember. So there's one study. Second study published this in 2020, done in the United States. 44 studies reviewed. Their conclusion, while contingency management interventions showed the strongest of evidence favoring outcomes, cognitive behavioral therapy alone and with contingency management was also effective in the target population. So now we have 2 votes for contingency management and then 1 vote for community reinforcement and 1 vote for CBT. This was one that was just done recently of cocaine treatment, systematic review and meta-analysis 2021. They were looking at cocaine. 157 studies, 402 treatment groups, 15,000 participants. Only contingency management programs were significantly associated with an increased likelihood of having a negative test results of the presence of cocaine. Conclusion, in this meta-analysis, contingency management programs were associated with reduction of cocaine use among adults. So 3 meta-analyses, all 3 cite contingency management. This one was published by my colleagues here at the University of Vermont last year, a little less than a year ago. This is looking at treatment for people who use stimulants who are in treatment with buprenorphine and methadone. So they're looking at what do we know works with that population that's on medication-assisted treatment, but they're also using stimulants. And they did, they looked at 1,400 results, 74 studies that were relevant, 11,000 participants. What they found was contingency management was associated with the end of treatment outcomes in all 6 of their measures that they looked at, and none of the other treatments met these same benchmarks. So again, in this study for people on MOUD, only contingency management showed as a robust treatment effect, and it reduced stimulant use, it reduced cigarette use, illicit opioid use, improved medication adherence, and a couple of other things. So four meta-analyses, all 4 of them citing contingency management and a few others. This was, and that, just to show you how ridiculous this industry has gotten in looking at this topic, this is a systematic review of reviews. So they're sort of one step above a meta-analysis of meta-analyses. And they looked at 29 different projects with different kinds of treatments. Again, the strongest body of evidence was for contingency management. You won't find in our field of addiction treatment any other situation where we have such a uniform recommendation for one treatment approach. I mean, even with opioid use disorder, I mean, we have different medicines. We've got buprenorphine and methadone, and some patients take naltrexone. But with stimulant use disorder, contingency management really is the, by far outweighs everything else. All right, what is contingency management? Contingency management is a very, very simple concept. It is providing incentives to incentivize reductions in drug use. And the most common way of doing that is to provide people with tangible rewards, often gift cards, $10 gift card for a gas station, $15 gift card at Target, a $20 gift card at Walmart. It's all set up per protocol, exactly what you earn and how much it increases over time and how long you do this. But it's simply this applying this incentive when people engage in behavior that indicates they've reduced their drug use. The most common way to do this is using urine tests. So what you're doing is providing incentives for stimulant negative urine samples. California is just getting set to do a $58 million rollout of this. California has had a massive problem with methamphetamine, has tried all kinds of different therapy sessions, inpatient, outpatient combinations with very poor outcome. And so they've decided to go big into contingency management. And so it'll be the first, the VA uses contingency management, but this will be the first contingency management rollout in the US in something the size of the state of California. The essential elements are the target behavior must be readily detected, in this case, urinalysis. And we're only looking at stimulants for this, to give the incentives. If you say we want you totally abstinent, this isn't going to work very well. You're setting the bar too high. And so that often can be challenging to some treatment programs. Like, what? We're only going to be giving them incentives. So if they're using cannabis, we're still going to give them the incentives. Yeah. The reinforcers need to be delivered immediately. So that means if you're doing this for stimulant use disorder, you have to have point of care testing. You have to be able to test immediately and have the result immediately and give the reward immediately. If the person gives a sample that has stimulants in it, they don't get punished, they just don't get the incentive. And if they miss a session, that's the same as if they give a positive test. So in general, in the studies we're seeing all over the country that we're involved with, everybody pretty much is using negative urine samples as the target behavior. The reinforcer, you have to make sure that you're using something the individual wants. So we found that gift cards at a number of different outlets is really a good way of doing. In California, they're actually going to be using a credit card where money is put onto the credit card so people can use it for a whole range of things. As I said, timing is important. And one thing I don't have on here that I need to add is the fact is to modify the behavior of somebody using methamphetamine or cocaine who's really dependent upon it. You're not going to do this by giving them candy bars or giving them an occasional prize or a good parking space. Those things are all very nice to do in your treatment program, but that's not going to work to reduce their stimulant use. Our recommendations and the recommendations of the groups that I work with are a realistic amount is somewhere in the neighborhood, a maximum of $100 to $200 a month. That if they do it perfectly, that they could earn that much. That's been a real challenge. Where does the money come from that? And for that, and that's one of the things that we've spent a lot of time working on. And California's project is actually the first in the country that's sort of broken through that issue. Have it in their state waiver now, and it's now a mainstream treatment in California. Al and I are working with other states doing that. And I think that because the stimulant epidemic is so severe and the overdose death rate is so high, people are saying, all right, well, we weren't crazy about the idea of, giving people stuff for drug-free urine samples, but if it works, maybe we should consider it. So at the current situation, we've got contingency management with all those reviews and meta-analyses, and we've got some other things. Cognitive behavioral therapy, CRA, MI, and some of the work that we've done on physical exercise. And I will now turn it over to my colleague, Mr. Hassan.
Thank you, Dr. Hassan. All right, so let's talk briefly about some of the treatment approaches other than contingency management. One of them is the community reinforcement approach. CRA has been around for quite a while, since the 70s and 1970s, and it was really developed as a way to treat alcohol use disorder. And really what the goal here is to modify a person's environment in such a way that it can compete with the effects of stimulant use, of other substances. And so as a way to do that, let's see, as a way to do that, it's important to involve people within an individual's environment. Some of the components of community reinforcement approach are helping people to develop some skills, to include recreational and social activities in their life, bring marital therapy or bring their significant others into the treatment field, and to help those individuals as well learn to be able to support and reinforce the individual when they are doing well. And as we know, quite frequently, individuals who have been using for a significant period of time generally might not have the support of their family. And in some instances, the family members have basically said, look, you're on your own at this point in time. And community reinforcement approach really does bring in family members. Using motivational enhancement, really motivational, combination of motivational incentives, but also using motivational interviewing, job counseling, and relapse prevention. There are a couple well-developed community reinforcement approach programs. One is the Adolescent Community Reinforcement, which is CRA, and then also the Community Reinforcement and Family Training, which is called CRAFT, and they are incredibly effective at addressing substance use disorders in individuals. So some of the topics right out of the gate, and you might recognize the functional analysis. Functional analysis is used in programs like the Matrix model and other CBT models, such as that developed by Kathy Carroll at Yale University, talking about drug refusal skills and assertiveness training, teaching people how to interact within the community to really promote pro-social behaviors, promote recovery, getting them to recognize that, you know, it's important to have fun. It's important to have good balance in your life, including exercise and recreational activities, along with employment or educational pursuits as well. And so really trying to help to develop a meaningful lifestyle in such a way that it is rewarding and that they're not just constantly looking for substances to change how they feel. And as Dr. Rawson mentioned earlier, you know, that anhedonia that goes along with this stimulant use is very profound. And so it's going to be important to have sort of things and activities, people, places, situations that individuals look forward to in their life. Regarding the functional analysis, this is really an opportunity for therapists to become curious, to find out about an individual's stimulant use, the good things about using stimulants and the not so good things about using stimulants. Finding out sort of the nature of their use, the people that they use with, the times of day that they're using with, you know, what is going on with them, you know, both emotionally as well as behaviorally, you know, when they use and, you know, prior to when they use, and after they use. So really gaining a really good understanding of sort of the nuances of a person's use and helping them to better understand what's going on. And also while doing so, we can understand how we can intervene in the process to help them abstain or continue to live a sober lifestyle. This is an example of the functional analysis that includes the 5 W's, you know, the time periods when somebody uses, the places, you know, what was going on, both, you know, external, were there external cues or triggers that were happening, and what were some of the emotional states were going on, who do they use with, or where do they get the drug, who do they get the drug from, and sort of what are the effects that they experience after they use and then even further along after that. Drug refusal skills, always important to do some role plays around drug refusal skills. You know, it's a lot more difficult than people, you know, really believe it to be, especially when somebody, you know, has the drug, you know, and it's presented in such a way that it can be incredibly triggering just to be in and around it. I always think of it as like kryptonite, and the longer that somebody is in and around the substance, the more likely they're to use, and the more likely that they're going to have a physiological response to either seeing the drug or being presented with it. And this is the topic or the handout that we use in the trust manual on drug refusal skills. This is an individual counseling session topic, and I'll go a little bit more into detail with you tomorrow on the individual topic series. Assertiveness training, you know, more often than not, interpersonal skills that an individual has or had prior to beginning their use are being challenged. It's really, you know, our goal is to help people recognize the internal and triggers in their life, be able to avoid those triggers, including drug using friends. And if in the event that they can't avoid, you know, those individuals, places, people, places, and situations, to be able to cope with it a little bit better than they would otherwise. And that's really where the role play comes in and gives us an opportunity to, you know, to monitor sort of a person's skill level in terms of both refusing substances, but also as a way to communicate with individuals who might present them with the drug. And here's the another individual counseling skill topic, and that's skills assertiveness training. So social and recreational counseling, lots of times I've heard people say, and you probably have as well, that, if this is what recovery is all about, I'm going to go back to using. Quite frequently, people don't find recovery enjoyable. They find it drudgery. They find it work. And the combination of the anhedonia that they have, the cognitive impairment that they have, the shame, the guilt, in many ways keeps them sort of from overcoming the inertia that recovery presents. And so what we're trying to do here is to help them develop a balanced life that includes recreational social activities. Hopefully this includes family members and people within their social circle who are not using substances, and in such a way that it gives them something to look forward to, and that can be incredibly powerful for individuals who don't necessarily feel like they should benefit from life, or that they should have a good time. And this really reviews some of the aspects of social and recreational parts of an individual's life. Really, what we're trying to do is to find out what are some of the things that they used to enjoy, get them re-engaged in those things that didn't involve drugs, but additionally trying to get them to think about activities that they might like to participate in that they hadn't done previously. We set some goals with them. We try to get them to focus on at least trying things that maybe they hadn't tried before, and looking at people who they can partner with. And certainly what we know from some of the exercise studies is making it easy for people to engage in exercise as well as other recreational activities is going to promote recovery. But additionally, if we can get other people in their circle of friends who are not using to participate, it increases the likelihood that they're going to engage in those pro-social behaviors. CBT, most of you are all familiar with CBT. It's based on social learning theory. And really the goal is to be able to encourage people to support individuals in stopping their harmful behavior, including substance use. The goal here is also to be able to look at some of the negative thought patterns that might impact an individual, both emotionally and behaviorally, so that when they do have those negative thoughts, we can give them the tools to intervene in such a way that those negative thought patterns don't lead towards using substances. We also want them to make their environment safe. Look at drugs in their environment, drug using friends and paraphernalia. Have friends and have family or acquaintances, help them to clean out whether it's their car or their house or places where they might have stored drugs or drug paraphernalia. Learn to develop or learn to recognize those people in their life that contribute to their use, whether it's their dealer or long-term using friends or family members, and figure out an intervention to reduce the potential impact that they have. And again, going back to CRA, practice those drug refusal skills. Some of the, these are all really part of the drug cessation group. This is another topic, 5 common challenges, looking at drug using friends, emotional triggers, such as boredom and loneliness, and also evaluating sort of special circumstances or anniversaries, weddings, birthdays that can challenge a person's recovery. Holidays, for instance, sometimes people have never gone through a holiday without using a substance, without celebrating. And here's the topic. And we also go into internal and external triggers. And this is the internal trigger chart, where we help people to identify those internal trigger states, internal emotions, whether it's being depressed or excited whether it's feeling, guilty or shame, and how they contribute to that negative thought patterns that ultimately might lead them towards using. And then we look at external triggers as well, sort of, certain behaviors, situations, people, times of day that might move them towards using substances, so that we can set up interventions to help an individual get by a certain part of day. That the Miller Brewing Company, they did such a great job with their advertising. It's Miller time. And so, it normalized the notion that I get off at work at 5 o'clock and it's okay to drink. And really that's not how it should be. And then this is a trigger chart where we help people to identify safe people, places, behaviors, situations that they should engage more in versus those very risky, people, places, and situations where there's more of a likelihood that if they meet those people or engage in certain activities or find themselves in certain parts of a neighborhood, that they're always going to use, and help them figure out ways to avoid those situations and placing themselves, at risk. One of the other drug cessation topics is the brain and stimulant recovery, and it's crucial that patients have an understanding of conditioning, that people understand how stimulants change the brain, the way their brain works. They're not functioning on all cylinders, and we do know that if they do stop using, their brain is going to heal. The fact of the matter is it's going to take some time doing that, and there are some challenges that they're going to face along the way that they may not be prepared to address. Motivational interviewing. If you've been in the field, in the profession for longer than a couple of minutes, that MI is crucial, and your ability to relate to patients using MI is most notable, and if you don't, you're going to realize that people aren't sticking around, people aren't being retained in treatment. And what we know that the research shows that there's a positive benefit by counselors using MI, lower cravings and increased retention. But additionally, what we know about motivational interviewing is that it reduces burnout for the counselors, and that's crucial, because what we know is that you work with the most difficult patients in healthcare. And as Dr. Rawson described, many of these people don't even realize that they need the care that we provide. This is, you'll be provided this slide deck, and what I'd like you to do is to be able to take a look at this handout that was developed by Case Western Reserve University. And really, it's a self-evaluation on whether or not you are using motivational interviewing. And I love the first one. It says, do I listen more than I talk? And that's one of the things that we really have to take a look at, is our own process in terms of either creating discord with our patient or creating a harmony in such a way that it allows them to be retained in treatment. It allows them to share some of the deepest, darkest secrets that they have, and yet continue to focus and work on goals that they've established along with us. We know that the spirit of MI is crucially important. I'm not going to spend a lot of time on this because it really isn't meant to be a training on motivational interviewing. But if you are utilizing motivational interviewing and embracing the underlying spirit, ultimately you're going to be able to partner with the individuals, show compassion and acceptance for who they are and what they've done, and ultimately that's going to get them to be able to share more and more of their life experience as it relates to their substance use and things that have happened to them, which will ultimately help them be successful in their recovery. We know that the processes of MI are engaging, providing that atmosphere of trust and respect and safety, helping people focus on a change that they've identified that they would like to, helping the individual share those, the reasons, their desires to make that change, and helping them to commit to making changes. And if you can get the planning, that's great. But certainly what we know is that if you continue to engage them, continue to get them focused, and get them to talk about sort of what their plans are for the future, you're likely to be successful. The tools are, using those open-ended questions, providing those affirmations. And the key about those genuine affirmations is that they ultimately decrease sustained talk, increase change talk. And if we can get people talking about change, if we can get them talking about their ability and the reasons and need for making change, we can feed that back to them through summarizing and affirmations, and allow them to sort of hear it multiple times, hear those sort of the aspects of change that they find useful, that they find important. Ambivalence is normal. We know that especially with stimulant users. Many don't realize that there is a need for treatment, and the drug is so powerful these days, so readily available and so cheap, that they may not realize the ultimately the damage that they're doing, both to to themselves physically, as well as to their social network and their family. I mentioned change talk. I'm going to just bounce through this. In terms of eliciting change talk, and Pascal said, people are better persuaded by the reasons they themselves discovered than those that come into minds of others. And how true that is when we're arguing for a point, generally what we hear is what we end up arguing, and not necessarily what the other person brings to the table. And so giving people an opportunity to talk themselves into recovery, and to recognize the value of recovery is really at the heart of change talk, and at the heart of motivational interviewing. It's going to be important for us to listen, as therapists, and to be able to identify change talk, and to be able to sort of highlight the change talk while softening sustain, and not arguing with the individual about why they need to be in treatment, or pushing back on that. So if we can just pick out the change talk, and provide affirmations or the change talk, ask open-ended questions regarding the change talk, or ask them to elaborate a little bit more about what they mean as regards to the change, I think ultimately we're going to get them moving in that right direction. Listen to understand, and that's the goal. All too often as therapists, we listen to ask a question, as opposed to listening, understand how a person feels about a situation, really what they mean about what they mean about what they had just said, and ultimately, if we can listen well enough to be able to elicit change talk, we can sort of move the conversation in a direction that will lead to change, reinforce positive change, and allow us to provide those affirmations that ultimately will promote change talk and change. And I think at this point, Dr. Rustin, I believe I turn it back over to you.
Yes, sir.
All right.
Yes. Now, what Al is reviewed along with contingency management, those are the when you look at these guidelines, those are the tools you're going to see that have years and years of research support of one sort or another. We did a study at UCLA starting in 2010. It finished around 2014, and we published 8 papers out of this study. It was a study designed to assess exercise for the for people with methamphetamine use disorder. The rationale is we know now physical exercise is one of the best interventions we have, including the medications, by the way, including antidepressants, for treating people with depression disorder and anxiety disorders. The data on exercise for those symptoms is really powerful. And of course, there's a wealth of exercise being beneficial for all sorts of other medical and psychiatric disorders. So we wanted to see what would happen if we added exercise to ongoing treatment of people for methamphetamine use disorder. We work with a treatment center, a long-term recovery program, 120 days residential program. People who came in with meth use disorder were offered the option of being in a study where half of them would get 3 times a week exercise for 8 weeks, 24 sessions, or they went to 24 health education classes as a control. And both groups got the standard residential treatment program. We had a NIDA grant to do this. We had all kinds of measures, and the results. Al, I'm not. Can you forward it for me? We ended up with 69 people in the exercise group and 66. They all met criteria for methamphetamine use disorder, these were pretty severe. People with pretty severe meth use disorder in California. In order to be admitted into a long-term residential care, you had to meet a criteria of very severe meth use disorder to go into the program. So these were people with severe meth use disorder, and they were equally randomly assigned to either health education or exercise. Next slide. I won't go through all the details, but as I said, we've published 8 papers out of this data set. What we found is if you, when we delivered it in a residential setting, we were able to get very good participation. The average number of sessions that an individual got was 20 out of scheduled 24. So when they're in residential, many times they said, oh, thank God I get to go to exercise. I'm so sick of being in group. Let me go to the exercise program. So there was good participation and they got a good dose of exercise. The exercise program was run with a trainer. So we actually had an individual who individualized the training program. They had a physical exam at the beginning to make sure it was safe and that they had no, other medical concerns, cardiovascular issues or others. And what we found was, first, their physical conditioning improved. The exercise protocol was about 40 minutes of aerobic exercise on a treadmill and about 15 minutes of strength training, arms, shoulders, legs. Obviously, after the 8 weeks of exercise training, the people who were in the exercise group were in better condition. They had more body muscle, they had less body fat, they were, their blood pressure was lower, they had a number of other beneficial medical indices. They gained less weight. For people when they go into residential care for stimulant use disorder, they're often emaciated when they go in, but they often gain a lot of weight while they're in treatment, and that can be quite distressing for them. The exercise group gained significantly less weight. We did a whole battery of cardiovascular testing. Those in the exercise condition after 8 weeks showed 4 different measures of improvement of cardiovascular functioning. Anxiety and depression were the biggest, most robust changes, very dramatic improvements. Now, when somebody's in a residential program, their anxiety and depression is going to get better from, assuming they stay there. But this showed that with the exercise, you got much more rapid and much more profound improvement. They would actually say how much better they were sleeping, how much better they were able to function on their group stuff because they weren't anxious and, attention deficit-ish, and so they really found that useful. Their craving was reduced, big reductions in craving. That we did with a subset of them, not all of them got this, but I think we did about 15 in each group. They got PET scans at the beginning and after the 8 weeks of training or the control condition. We found the dopamine system, the D2 receptors recovered to a much greater effect than those in the control condition. So part of the way that this benefit of exercise was manifested was by getting the dopamine system back to normal more quickly. And finally, when they were discharged from the residential program, we followed them up and collected urine samples from them, almost 90% of them, at 1, 3, 6, and 12 months post-discharge. And what we found was there was a group, about the top 10% in each group, the very, very heavy users, where we didn't see much benefit to exercise on reducing relapse. But among about 90%, those that were everybody except the most severe, we saw a much lower relapse rate to methamphetamine. It was something, I think it was something like when we looked at the control group, we saw that at 90 days, about 60% had relapsed back to methamphetamine. Now, when we talked to the staff of the clinic, they were pretty surprised at that. They didn't realize there was that high a relapse rate. But with the exercise group, it was about half that. So exercise also reduced relapse. We think exercise is going to needs more research, needs to be figured out. How do you get them to do it as part of treatment? But that if we can figure some of those practical issues out, it really is, if based on the data we got, if exercise was a medicine, it would be approved by the FDA because it was safe and effective in reducing and producing lots of positive effects. Next slide.
Hey, Rick, Francis Bodner mentions that if you add music to exercise, it makes it a lot more enjoyable and better.
Yep, and one of the things that Al and I are trying to do is, in some of the projects we're working at around the country, is how do you get people to exercise? What are the things that facilitate exercise? And the idea of doing it together with music is great. If people want to be on a treadmill or Peloton bike or something like that, they can watch, videos of things. Some people do it with buddies. They go to the gym. They join a basketball team. I mean, there's a lot of different ways of getting good exercise. It's just getting the patients to see it as a piece of treatment, that this isn't like a filler. A lot of treatment programs have their treatment stuff, and then you got free time, so you might as well exercise, or you can go use the machines. But there's not a sense of prescribing it as part of treatment. And we think that the results are so promising that people really should start considering getting people into exercise as a sort of the way they do getting them into 12-step programs. That this is a form of support that really has tremendously valuable benefits. There actually is an organization that slips my mind right now, but is all over the country, that provides free gym memberships to people in recovery. We think that might be a good way to get some people. But let me go on. I just want to mention the medications. Next slide. For cocaine use disorder, no, first off, nothing has FDA approval. So we don't have, like we do with the COVID vaccine, where we've got 4 or 5 different COVID vaccines that have been approved by the FDA. And like we have with methadone and buprenorphine and naltrexone for opioid use disorder, we have nothing for stimulants that have been approved by the FDA. These are some of the candidates. Some doctors use these off-label in the treatment of people with cocaine use disorder. But I have to say, Al and I were involved in many, many of the trials on these different drugs, medicines, and nothing knocks your socks off. It's not like some of these are, wow, that's a pretty strong effect. This patient really did better. You get a little bit of an improvement, maybe. But when you compare it to placebo, it doesn't show a difference between the medicine and placebo. Next slide. And these are the ones for methamphetamine. There are 2 that are have have several studies. Mirtazapine, we need to fix that. That's an M. It's mirtazapine, which is an antidepressant. There have been 2 trials, double-blind, placebo-controlled trials, where mirtazapine has been useful in reducing meth use compared to placebo. And there's been 1 trial with the combination of naltrexone and bupropion, or Wellbutrin is the trade name, when used in combination, had a beneficial effect for about 1 person in 10. So it's not as though it's a home run, but they do have, in the placebo group, it was 0 out of 10. So they got this finding that this combo drug seemed to be better than placebo in a very small way. But there's a lot of research that needs to be done. We're not really close yet, I don't think, to having a medication. So as we look at these behavioral treatments, particularly contingency management, that's where we have likely the best chances of significantly improving our outcome with people with stimulant use disorder. Next slide. Oh, I guess I can do it. Yes, okay, that's brings us to the end. Now, Al's going to talk with you tomorrow about how he and I have tried to combine some of these things into a protocol that people can use, and he'll give you the website where, it's something you can use. You don't have to, there's nothing to buy. It's downloadable. It's got lots of patient handouts and therapist pointers and all that. And so he'll be giving you a description of that material, and it sort of tries to borrow from all these things that we presented you today and put them into one integrated package. And it's, we haven't done research with it. We don't have any indication that it's better than anything else. It's just something that if you find it something that can be helpful to you, we hope you can get some benefits from it. So we'll stop there, and I think we've got a few minutes for questions.
At this time, I don't have any in my chat. Do you or Albert have any at this time?
I do not. But I did list the Phoenix, a National Sober Active Community. I think that's what you were referring to, Rick.
No, that's not it. It's there's a company, and it's is it the Phoenix program? Maybe that's it. Yeah, maybe you're right. Maybe it is called Phoenix. I know there's about 8 of them in Los Angeles that we've gotten some patients to engage in, but maybe before tomorrow we can check into that. I do have a question from Francis that's asking, any over-the-counter drugs that may reduce drug use, not for stimulants that there's any evidence to support. In fact, over-the-counter drugs can complicate your monitoring their drug use by urine tests, because some of the over-the-counter drugs that have pseudoephedrine in them, things like medicines for asthma and hay fever and allergies and all of that stuff, that may have ephedrine, pseudoephedrine, to keep your eyes from running and your nose from running. That over-the-counter drug can often cross-react in urine tests and show up as methamphetamine. And so you have to talk to your patients about not taking medicines like that. What are some of the common ones, Al? NyQuil, I think, has pseudoephedrine in it. And a lot of those packages of allergy medicines have pseudoephedrine in them. So if you've got patients that are taking a lot of those, they're going to show positive urines. Some of them will anyway, from the over-the-counter medicines. You need to let them know that they shouldn't be using those while they're in treatment. Antihistamines, thank you. Benadryl, right? Yeah, those things are they're just challenging. I mean, it's not like they're hurting themselves. It's just going to mess up their urine test results. Well, thank you. And Al will be wrapping up with you tomorrow. If there's my email, and I'm sure he'll give you his email tomorrow. And feel free to send us questions, and we will answer them. I got one from yesterday that I haven't gotten around to, but I will answer today or tomorrow. And we hope you find the information useful.
Take care.
Well, thank you so much, Dr. Ralston and Mr. Hassan. This was great information to share with us. And tomorrow we'll pick up the third part of our 3-part series. And we will be doing this series again at the beginning of April as well. And if you would look over in the chat panel, we have a couple of items of business to note before we conclude today. A link to today's evaluation is in the chat panel. Additionally, when I conclude today's webinar, your browser will take you to an evaluation on our website. If you would like to receive CE credit or a statement of credit for this event, you must complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of License prefix and number. After you register or sign in, you will be directed onward to the evaluation. You will need to use the same email address you used today when you registered for our webinars that you have listed on your FADAA account. That is how we connect your attendance and your profile together to give you CE credit and statements of credit. You will get a second opportunity to complete the evaluation today through a follow-up email from messenger@webex.com. Please note that the evaluation will close Monday, March 28th at midnight. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile within 30 business days. Then we'd also like to especially thank you for participating in today's webinar and recognize the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. Thank you so much and have a great rest of your day.